She's here. You can, Dawn has the index cards if you don't have one and you want to write a question. Okay, just one or two more people coming in. I'll get started. Good morning, everybody, on this rainy, exciting morning out there in the world at large, and we're going to be safe and cozy inside this little auditorium. Welcome to the Department of Human Services and Department of Health Joint Community Forum. The purpose of this meeting is to outline the upcoming changes to health services for individuals currently receiving mental health services from the Departments of Health and Human Services. The changes that we're going to be outlining today take effect September 1st. My name is Kayla Rosenfeld. I'm the Department of Human Services Public Information Officer. I'm going to be your moderator today, and the program is an integration and expansion of behavioral health services for Medicaid beneficiaries. Again, before we begin, want to make sure everybody had an opportunity to write a question down or has an index card to write a question. I will ask Dawn to collect them toward the end of the presentation so that they're available and ready to go when we're done, and then we'll have our individual panel members answer the questions. Let's see. Want to welcome our Neighbor Island participants. We have Neighbor Island folks from Maui, Hilo, and Kauai, and at some point during our session we will bring them up on the video so we'll be able to interact with them. Would like to remind you, cell phones off or on stun, please? Stun, yes, stun. If anybody jumps, we know what the story is. Okay, so let's get started. We're going to begin with a brief overview of the Department of Human Services, Medicaid, and Behavioral Health Services and the delivery system. Our Healthcare Services Branch Administrator from the MedQuest Division, Patty Bazan, is going to get us started.
Good morning. Thank you for having me today, and thank you for coming. I know that with Tropical Storm Flossie, we were all a little nervous, and I'm glad people, braved the storm and came out to join us today. My name is Patty Bazan. I work for the MedQuest Division, which is, under the Department of Human Services. We're responsible for oversight of services for our Medicaid beneficiaries. And my branch is primarily responsible for oversight of healthcare service contracts. So if you're touching one of our beneficiaries, probably the contract that does that is in my branch. So we'll be talking about some changes that we're doing today. So our outline, we're going to go over the purpose and goals, we're going to go over some background information, the proposed transformation, and then some Q&A. So what is the purpose of the meeting? Is to inform consumers, providers, and organizations about the Department of Health and Department of Human Services plan to integrate and expand behavioral health services for our adult QXA members. So what are the goals? Provide more services to more beneficiaries. To ensure clinical continuity, to simplify system navigation for our beneficiaries, to improve service delivery integration, to reduce administrative burden for providers, to improve efficiency of state programs, and to optimize federal matching funds for claiming. So how do things work? How do things work within Medicaid when we talk about behavioral health services? All of our Medicaid beneficiaries have access to standard behavioral health services, and those with SMI or an SPMI have access to specialized behavioral health services. So what's a standard behavioral health service? That includes, access to a psychiatrist, a psychologist, psychotropic medications, any acute psychiatric hospitalization, substance abuse. Those are what we consider our standardized services. And we'll also have a few more standardized services we'll talk about later. We also have specialized behavioral health services, and this is case management, psychosocial rehabilitation, clubhouse, intensive outpatient hospitalization, peer specialists, supported employment, and those are specialized services. So once again, all of our beneficiaries have access to standard services, but only the individuals with SMI or SPMI have access to specialized behavioral health services. So we have a program in DHS, it's called our Community Care Services Program. And this is a DHS program that provides behavioral health services to Medicaid beneficiaries who have SMI or SPMI. DHS started this program in the mid-90s, and we've had the program since then. I think sometime in 1994 we started the program. The CCS contract is a full risk capitation with responsibility for complete scope of behavioral health services. The CCS contractor is required to coordinate with our health plans. And the CCS contractor for CCS is Ohana Health Plan. And currently they're providing services to about 800 of our members. They took over that program in March, and I think that we'll have Wendy speak a little bit about CCS. So our current status, this is what we're doing right now for our Medicaid folks. Does it look confusing? Absolutely. Is it confusing? Absolutely. Is everyone confused? Completely. And this is one of the reasons why we've been working with the Department of Health for the past couple of years, because we have a hard time figuring out what's going on, and if we can barely figure it out, we are sure that our consumers and our providers can't figure it out either. So what's going on the Quest side is that anyone non-SMI, SPMI has access to standard behavioral health services from their Quest health plan. On the QXA side, also non-SMI, SPMI has access from their QXA health plan. What gets complicated, that's not very complicated, but what gets complicated is when someone has SMI or SPMI. So under Quest, you have both standard and specialized behavioral health services being provided from a Quest health plan. And that might not look very complicated, but when you have 5 Quest health plans, and no one really knows when somebody comes in as a provider if someone's in Quest or if they're in QXA, and you have to figure out who's providing these services and who do I make a referral to, that can be very complicated for our providers, especially folks like in our emergency room where things, someone will show up in the emergency room, it can be very, very difficult to identify who's providing those services. It gets even more complicated on the QXA side because if someone's receiving services, if you look on the QXA to the left, if someone's receiving services from the Adult Mental Health Division, what they're receiving is only their specialized behavioral health services from Adult Mental Health Division, but they're receiving their standard behavioral health services from their QXA health plan. So Adult Mental Health Division is unsure if someone's receiving what psychotropic medication someone is on. Are they getting med management? They're unsure if there's been an acute psychiatric hospitalization. They're unsure if there's even a psychiatrist in place. And because they don't have access to that information, the QXA health plan has access to that information. In addition, the QXA health plan does not have access if someone's receiving case management from a provider in the community, an adult mental health, POS provider in the community, or even a community mental health center. If there's any PSR going on, the QXA health plan doesn't know that. It's really very, very siloed right now. Then we have these 800 individuals who are receiving all their standardized and specialized behavioral health services from CCS. So those individuals, there is a lot more coordination between the QXA health plan because we've identified who these individuals are, the QXA health plan knows that they're in CCS, and there is more communication. But on the other side, there's not, and that's where the majority of our folks are sitting right now. So this is our current status. What we're trying to get to in phase 1 of this process is this next slide. So very much like Quest, standard behavioral health services, non-SMI, SPMI. But the difference is that anyone in QXA will receive their SMI or SPMI services from CCS. So still that confusion between are they Quest or they're QXA, we still have that confusion. But the difference is instead of going to 5 different health plans, there'll be one place to go to receive those standard behavioral health services. So that's phase 1. What's phase 2? Phase 2 is we're going to still have our Quest and our QXA program, but we're going to take all of our individuals from Quest that are receiving specialized behavioral health services, and they're going to move them into CCS. And so this is phase 2 of our process. So someone's receiving specialized behavioral health services, they have Medicaid, you know where to go. They go to CCS. Still SMI and still non-SMI, SPMI will be through the health plans. So now we move into, which we're not going to spend a lot of time talking today, but phase 3, which is our Quest integration program. And the Department of Human Services is going to be reprocuring our Quest and our QXA programs and combining them into one program called Quest integration. So we're not going to have 2 different programs, and you're not really sure if someone's in Quest or you're not really sure if someone's in QXA, and you're not really sure how someone gets from Quest to QXA. We'll have one program called Quest integration, and they'll get their standard behavioral health services, non-SMI, SPMI from their Quest integration health plan, and then SMI or SPMI services through CCS. So we're hoping that in the next year plus, we're going to be able to move into phase 3, which is going to be a lot more streamlined for folks that have Medicaid. So what are the timelines for this? So we actually changed our CCS program to a behavioral health organization in March of 2013. We had been running I said we'd been having the CCS program since 1994. And we'd actually been running it as almost a third-party administrator. So case management services and administrative functions occurred through CCS, through the CCS program. What would happen is CCS would pay claims, then they turn those claims over to the MedQuest division. And for various different reasons, we felt that we were better off moving to more of a behavioral health organization with regards to that versus sticking as a third-party administrator. So we started doing that March 1st, 2013. We're looking at transitioning our QXA members with SMI or SPMI and receiving their specialized behavioral health services on September 1st. And really, we'll talk about this presentation. We'll go through what the transition plans are for that, how we're protecting our beneficiaries through that process. But when we're looking at this through MedQuest, and even as we've been discussing this with Department of Health, the main way that we're looking at this is really the September 1st is much more of a transition of who our providers are billing. And we'll go through more of that in the future. We're looking at doing phase 2, the transition of Quest members, sometime in 2014. We don't have an exact date for that yet. And then we're looking at implementation of our Quest Integration Health program on January 1st, 2015. So when we talk about SMI, SPMI, when we talk about eligibility criteria, what does that look like? So right now, anyone with a schizophrenic disorder, schizoaffective disorder, delusional disorder, mood disorder, either bipolar or depressive, can come into CCS. And we'll talk about some other functional eligibility criteria in the next slide. We're also trying to work with our federal partners right now, Centers for Medicare and Medicaid Services, to try to add substance-induced psychosis, and post-traumatic stress disorder. These are 2 diagnoses that we're trying to add, fingers crossed, October 1. And if we can get those in place October 1, then we'll start being able to add those to our CCS program. We're very excited about adding those diagnoses. So it's not just a diagnosis, because we also have other criteria. So we need that individual demonstrates the presence of a qualifying diagnosis for at least 12 months, or is expected to demonstrate that diagnosis for at least 12 months. And then meets at least one of the criteria demonstrating instability or some type of functional impairment, either a GAF score less than 50, clinical records that demonstrate the member is unstable under their current treatment or plan of care, requires any kind of protective services or intervention by housing or law enforcement officials. So those are the types of criteria we use. In addition to that, what we find is that not everyone fits into this kind of a box. There are individuals that really benefit from our CCS program that, maybe we're unsure if their diagnosis is going to be there for 12 months, or that, their GAF score might not be 50 yet, or they might not have had a run-in with law enforcement, but there are criteria that we think they would benefit from CCS. And in those cases, what we do is our MedQuest division medical director will take a look at those cases, and we'll bring them into CCS. And we do this, I don't want to say on a regular basis, but we do this, and I can think of a number of cases where we've done this. So we do want to treat individuals, and we do want to bring people who can benefit from CCS into that program. It's not a way to exclude folks, it's a way to actually include. So what services are covered under CCS? Inpatient psychiatric hospitalization, ED, crisis management, med management, diagnostic services, substance abuse, intensive case management, intensive outpatient hospitalization, PSR, specialized residential treatment, individual and group therapy, Medically necessary therapy services to prevent institutionalization. If somebody needs a service to prevent institutionalization, we will provide it under CCS. And then also maintenance of members' Medicaid eligibility. That is a very important service, though it doesn't really look like a medical service, but it is part of their contract because it's very important for our Medicaid beneficiaries to maintain and keep their Medicaid. If they continue to maintain their eligibility, the chances that they're going to continue to receive services are very high. We also have 5 services highlighted in yellow, and these are services that we have actually submitted to the Centers for Medicare and Medicaid Services, CMS, to actually have covered with federal funds. And we feel relatively confident that we are going to be able to have these services added, and the add date for that would be October 1. And we think that this is going to be just a way to actually help us expand services we're providing right now. So these are peer specialists, clubhouse, supported housing, representative payee, and supported employment. So the main one that most people ask me about is this supported housing. What's supported housing? What do you mean by that? Are you going to put people in housing and pay for their housing? That's not really a Medicaid covered service, but what we will do is we will actually have the ability to pay individuals to help people find housing and maintain that housing. So, filling out rental applications, going with the individual to see an apartment, training individuals, what do you have to do to maintain housing? What do you have to do to stay in this housing? And working through that with individuals. So that's a very new function for Medicaid. We've never done that before. And we're going to be, working through that as we get approval from CMS. So at this point, I'm going to turn it over to Kayla Rosenfeld to introduce Department of Health.
Thank you, Patty Bazan, Department of Human Services, Healthcare Administrative Branch. Okay, reminder, this session is being recorded and it will be posted on our DHS website. There'll also be connection to DOH, so if you miss anything, because there's a lot of complex material in here, the presentation will be posted along with the questions and answers that we received today as well. So we turn now to a more detailed explanation of the transition of the Department of Health and the Department of Human Services integration. And from the Department of Health, we now meet Dr. Mark A. Fridovich. He's the administrator of the Adult Mental Health Division, Department of Health. Thank you, sir.
Thanks, Kayla. Thanks, Patty. Thank you, folks, for joining us. Good morning. Thanks for taking the time to be with us this morning so we can tell you about this important initiative. There are many parts to it. Patty's gone over some of them. We're going to go back over them in more detail. And it relates to a lot of other things that the Department of Health and the Adult Mental Health Division are doing and DHS are doing. And it also relates to a lot of things that are just happening generally, like the Affordable Care Act. So back to phase 1, transitioning from the Adult Mental Health Division to CCS. Effective September 1st, is that date correct? Yes. Ohana will assume some of the functions previously performed by AMHD, payment and manager of care for those specialized behavioral health services for the SMI, SPMI population. Adult mental health remains a QEXA provider through our Community Mental Health Center service delivery. The QEXA members who are currently at a CMHC can continue to be served at that CMHC if they choose. All QEXA members will be offered a choice of provider. This is a more detailed breakout of the timeline in phase 1, the transition timeline. DOH and DHS are identifying the DHS QEXA members who are currently receiving services from AMHD. We're doing this now. We're refining our identification of who the folks are. what programs they're in, what programs are going to be newly covered, and what programs will continue to be those provided by AMHD. The service provision referred to in 2, again, is mainly that notion of managing care and payment for care in the first instance. And then September, fiscal responsibility for most DOH, AMHD behavioral health services for this population transition to the CCS program, and assessments for the transition of care begin. Here's the transition process in greater detail. Our priority through all of this is clinical continuity of service through this process. We want it to be minimally disruptive, non-disruptive at all, if possible, to the recipients of service. CCS will assess its new members to ensure that consumers are receiving all medically necessary behavioral health services, the right kind, the correct intensity of service. Working through this group will take time. The CCS anticipates completion of the assessments will take approximately 6 months. And the AMHD prior authorizations, those are authorizations for payment and for continued stay. Those will be accepted by CCS until the assessment is complete and an updated care plan is developed. Here's our continuing responsibility for this group. It's not all, but pertinent to this transition. AMHD responsibility. We continue to pay for and provide full services for certain individuals as clinically indicated and in support of their recovery. Specifically, we continue to be responsible for all legally encumbered Medicaid beneficiaries. We will continue to have clinical responsibility for individuals who meet our eligibility criteria and are uninsured. We are a payor and a provider of services in that first bullet. AMHD will continue to manage certain services for all individuals. For example, crisis services for those who access contact our access line. We're a safety net provider of these population-based services. We provide them for all, regardless of AMHD eligibility. That's continuing. We're continuing to rebuild and expand these crisis and other critical services. AMHD will continue to offer, administer, and operate a portfolio of housing services and residential supports across a continuum. These are part of our continuing care supports, and these will continue. We're going to review them. We're going to refine them together with our stakeholders to better target how we can be most helpful to individuals in their recovery. We're going to try to expand these in some areas and to refine our programmatic offerings. And the last bullet on this page, AMHD will continue to certify providers for participation in the Medicaid Rehab Option Program, MRO. We do this by virtue of, in partnership with DHS, and it's consistent with our responsibility as part of the State Mental Health Authority for standard setting, certification, and monitoring progress. Strategically, we want to ensure treatment and housing needs are met for all. Some of the impacts on the beneficiaries. The QEXA members receiving case management and psychiatric care from a CMHC, again, will be able to continue to receive those services at the community mental health center. QEXA members currently receiving housing from AMHD will continue to receive this service from AMHD. 1 and 2 indicate these first 2 bullets. We're very concerned to maintain clinical continuity. We want this transition to be non-disruptive to our clients. That's our emphasis. I might say housing is a general subject in many discussions. We play a critical role, and so do others. We will continue to discuss, review, refine with our stakeholders how best to arrange these and all critical services. The AMHD consumers receiving services from an AMHD contracted provider may continue to receive those services from that provider since Ohana contracts with the same providers. And last, again, AMHD will continue to offer a continuum of clinical and housing supports to new QEXA and AMHD clients who may clinically require these. Crisis services, very important, critical, population-based service. Both AMHD and CCS will maintain a crisis line. There will be no wrong number. Eligible, not eligible, it doesn't matter. AMHD wants these improved. We're working towards that. They have improved. We have to go further. But both AMHD and CCS will provide these crisis services to anyone who calls and needs them. CCS members are encouraged to call CCS when they're in a crisis. Any services authorized by AMHD will be reimbursed by CCS. Some of the impacts on AMHD providers, fairly straightforward. All behavioral health service with date of service on or after September 1st, 2013, former AMHD members should be billed to Ohana Health Plan, the CCS program vendor. Providers should verify Ohana has all of your AMHD prior authorizations. Again, those will be good for the duration of that assessment, reassessment interval until the new care plan is developed. CCS will pay non-contracted providers for all authorized Medicaid rehab option services during the transition period. And last, providers that don't have a contract with Ohana are encouraged, and would like one, are encouraged to contact Ohana. Here are options for referral into the CCS program. And again, the CCS program, subset of individuals, severe mental illness, severe persistent mental illness. If a person has SMI, SPMI, and is covered, they should be referred to CCS. So providers should contact the beneficiary's health plan to initiate the referral to CCS for anyone who they believe will benefit from those specialized behavioral health services. AMHD will make referrals to the MedQuest division for anyone they serve who will qualify for CCS. We'll also do it directly through Access and the assessment unit for new clients. QEXA plans will make referrals to MedQuest for individuals who they identify as needing those services. And once a referral is approved by MedQuest, the beneficiary will be enrolled in the CCS program prospectively. Up next is Ohana. Michaela Rosenfeld will introduce our next speaker.
Thank you, Dr. Fridovich. As you've heard, the DHS MedQuest contractor for the CCS is the Ohana Health Plan. We awarded that contract in October 2012, and it took effect March 1st, 2013. To tell you more about the organization and its role in providing integrated services, we now hear from Wendy Moriarty, and she is the president of Ohana Health Plan.
Good morning, everybody. Hope we're all nice and we were prepared for the storm, the upcoming storm. I know we haven't checked in with the neighbor islands yet, but I hope you all are weathering it out there well in Hilo and Maui counties. So a little bit about Ohana Health Plan. I will be brief. I hope that most of you that are here and involved with the behavioral health system here in Hawaii are already aware of who Ohana Health Plan is, but just a few words. We have just under 200 associates across all islands. The only island we actually don't have associates residing is the island of Lanai. We've been here since 2009. I think obviously most of you know us as a QXA and Quest Health Plan. We are solely dedicated to serving public sector beneficiaries. So what does that mean? So that means we're not a commercial health plan. So all we do is we service Medicaid or Medicare members. So it's a little bit different, and obviously this has a lot of overlap with the behavioral health community. We've been serving behavioral health members since 2009. So most of our providers and most of our programs were already designed to touch this population. So it made sense when the CCS contract came out, we were interested in seeing if we could serve that population as well. So we were honored that DHS did select us. They are tough on their vendors, so I can assure you that we will be held very accountable. And that was one of the other things. From our perspective in working with the Medicaid population in particular, the system was really confusing. When we would even onboard new staff, we would go through our orientation and kind of explain what the Medicaid system, how it operated. And when we got to behavioral health, it was confusing. And we would even tell our new associates, give it 6 months and you'll understand how the whole system operates. And they'd go, 6 months? We'd go, 6 months, trust us. So we really do believe this is the right thing to do. It's going to be a single source of accountability. It'll be one vendor. You'll be able to pick up the phone and at least know who to call, instead of right now the way the current system is with being so fragmented. So our main office is located out in Waipahu. So if anyone's out in Waipahu, come visit us. That's where our call center is located. That's where the majority of our staff are located. That's going to be the basis of operations for our CCS contract. Since we've been here, we wanted to kind of show you what you might see as a provider or as maybe a CCS member. Again, since we've already been operating a state, some of our consumers may already have an Ohana health plan as a health plan operator card. So how are we going to differentiate what a CCS member card looks like? We gave it a gold stripe. So this is the gold plan, right? So this is what a CCS behavioral health card looks like. They don't have to have the card for services. They don't have to have the card as far as payment is concerned. But as a provider, we thought it would be important to kind of show what the difference is. I think one of the biggest changes with the CCS program that I'm not sure was highlighted, and I'm not sure if we have any of the pharmacies in the room. I know our pharmacist is in here. Hi, Dex. One of the things is the behavioral health medications are going to be covered by CCS. So it's very possible that a consumer could go into a pharmacy and need to be able to show the right CCS card or have the pharmacies know who to bill. So we've been doing this since March of this year. It's gone very, very well. It's gone very smoothly. So we believe most of the pharmacies are aware of this, but this is probably one of the other areas that would be a change to the current system. So we thought it was interesting to be able to show the card. The other place you can find out if a member is going to receive services through CCS is on the MedQuest eligibility website. I know most providers are used to going there to find out what health plan or if a particular patient has Medicaid. And you're probably used to that first tab that shows what their Medicaid health plan is. You may never have noticed there's a little tab if you click all the way over that says behavioral health. If you click on that, it will show you whether the member has CCS eligibility or not. Just wanted to put this up on the screen. I believe, again, most of you know how to find us and contact us, but we do have our website. It's ohanahealthplan.com, or you can go specifically to our CCS website, which is ohanaccs.com. Lots of different resources up there, copies of member handbooks, provider directory, how to contact Ohana, quick reference guide, authorization rules, or you can also contact us. This is our main 800 number. This will get you over to our call center in Waipahu. If you're on a neighbor island, in particular, if you're on Big Island or Maui, hopefully you know where our local offices are. You can also call the local office numbers or walk on in if you have a question. Like I said, since we've started this, we believe we've met with most of the providers. I'm proud to say most of the providers were already in our network when we received this contract. We are open to contracting with anybody. I think Mark mentioned there will be a transition of care period. So we've done this with the CCS contract as well when we went live with that. So any services that were prior authorized, we will continue to authorize. We will continue to pay the claims. If for some reason somebody's not participating, we can still pay that claim all the way through the transition of care period. And then on a case-by-case basis after that, it would potentially need authorization, but we can accommodate that as well, although we'd welcome all the different providers into our network. I'll call out Jamie Pu'u, who is our Senior Director over Network. She's here, so thank you. So she's available for you to contact as well as far as for getting a contract with us. So with that, like I said, we're honored that we were selected. We hope we do a good job for DHS as well as for all the consumer community. So thank you.
Thank you, Jane Moriarty of the Ohana Health Plan. Okay, so that sort of brings us to the close of the formal presentation. We assume that you have questions. If you've written up a question and you have on the index card, if you'd pass it to Dawn over here on this side, we'll take just a couple minutes to get that together, and then we'll ask questions. And then a reminder that this presentation will be posted on the DHS website with at least a link to DOH. I have not connected with my counterpart over at DOH to say where this information will be, but we have on DHS a page on the website specifically for this transition. Maybe I could take a moment and bring in our neighbor island participants who are participating via video from different sites around the state. As we said, Maui, Hilo, and Kauai. Can we bring in our neighbor island participants? Do they come up on the screen? Okay, so I'll ask the questions and then I'll turn to the panel and you folks can decide who's the best person to answer. No more eligibility determination assessments. What's the new process beginning September 1?
My understanding is eligibility determination assessments will continue, so we're going to do ours through MHD, as we have been. We are looking at changing eligibility criteria. Our process for that is different than DHS's through the MedQuest division, but the process for eligibility determination, though the criteria may change, will remain and will remain essentially as it has been.
Whoever posed that question, satisfied with the answer?
No, so MedQuest has always done the eligibility determinations for CCS. It's not, the vendor has never, Ohana is our current vendor. We've had other vendors previous. We've never had that vendor actually do eligibility determinations. But, you know, MedQuest is working with Adult Mental Health Division to try to streamline that process because we don't want Adult Mental Health Division to have to do two processes. But Adult Mental Health Division will be very much responsible still for eligibility determinations and then sending those referrals over to MedQuest for us to sign off on them. So, and then we also can take referrals from, you know, health plans. Providers should refer that to health plans. So, yes.
Okay. Next question. How do children or adolescents fit into integration? Examples, 12 to 17-year-old group.
So, Child and Adolescent Mental Health Division, CAMHD, will still maintain the role that they play today, and we're not going to really be making any changes with regards to the way CAMHD is providing services. I think the one difference is with the way we have things today, and you know, with adults can receive those specialized behavioral health services from multiple different avenues, whereas MedQuest has always recognized, or at least for the past, I don't know, 15 years or so, that CAMHD really does this very well, and this is not something we want to, you know, we've never actually tried to provide those specialized behavioral health services for children or adolescents. So they'll still maintain receiving their services through CAMHD, and, you know, we'll continue to still pay for those standard behavioral health services.
Sorry, trying to get our neighbor island folks on the screen. Next question, number of AMHD clients who will be impacted by this transition.
We're currently refining numbers. I believe an article in the paper today, yesterday's paper, indicated it's 4,000. Some of those 4,000 will continue to receive some AMHD services because they're not part of the new covered specialized behavioral health package. Some of those 4,000 are also continued clients of the CMHCs, our community mental health centers. So when I presented, I mentioned that we're refining the numbers and we're refining what are the service packages that the affected individuals, the individuals with this coverage who are going over to CCS, what programs are they in? So the large number is 4,000. Some of those might be individuals who are mainly receiving services at CMHC. Some of those who are maybe are receiving services through purchase of service providers will continue to receive some adult mental health provided services, perhaps mainly through our housing and other support service portfolio.
Okay. Couple of housekeeping type questions. Is United Healthcare the same as Ohana Healthcare? Do I read that correctly?
That's a really good question. No, there are two different health plans. The MedQuest division has contracts with 5 health plans, Aloha Care, HMSA, Kaiser Permanente, Ohana Health Plan, and United Healthcare Community Plan. So Ohana Health Plan is one of our health plans that's providing QXA and Quest services. United Healthcare provides QXA and Quest services. And then Ohana, on top of being Quest and QXA, also has the CCS contract.
Okay. I'm going to go through a couple more of these. I'm trying to get the neighbor island folks involved, and as soon as we get them connected, we'll ask some of questions from them. They're working on it. Okay. Where do grievances go? How do we do that? And there's specifically consumer and provider. How do we make our grievances known to the system? We all are jumping at this question, aren't we?
So, I think that there's, once again, no wrong door with grievances. And I think that if there's a grievance from a provider or a grievance from a consumer, if you're receiving services through CCS, we recommend that you go through CCS first. But there will be a process. There actually is a process right now for CCS members to also submit those grievances to Department of Human Services afterwards. But I'm sure that Adult Mental Health Division has the ability to take grievances as well.
Yeah, all of our continuing, all of our services that receive grievances, complaints, will continue, whether it's a provider issue, that'll go to provider monitoring. Client grievances, individuals being served who've got grievances, typically go to our Office of Consumer Affairs, but all of those will continue and they'll persist.
The question I just handed over there was regarding a roundtable. So just following up on the same question, just a little bit more detailed.
So just to add on a little bit to what was previously just answered, so absolutely there's information on the process for providers in the provider handbook. It's also on our website, how to file a grievance, how to, the different levels of grievance, how to do that, as well as on the member side. So members can file a grievance. They can do that even verbally through our 800 number. They can send it in. All of that information is also in our member handbook. I think one of the neat things too with the CCS program is what we're doing is the member is going to get a separate handbook that's tailored specifically to the CCS program. That's probably a little bit different than even what they've seen from their Medicaid health plans. So, and all of that information will be outlined in there. So the question here is, will they start a consumer roundtable and a consumer grievance office similar to the current Department of Health ones? And I think, we're open to different ideas and doing whether it's a, consumer roundtable, a consumer advisory board. So do we have one today? We don't. Would I rule that out in the future? Absolutely not. I think it's a great idea.
Okay, moving on to our next question, if we don't have our neighbor island folks up. Okay. In describing disorders eligible for CCS, the speaker cited many SMI diagnoses to ultimately include PTSD and substance-induced psychosis, but no mention was made of substance dependence, the central disorganizing diagnosis socially, economically in our state, even without comorbidity. Why?
We, MedQuest Division does treat substance abuse disorders, and we very much provide services with, related to substance abuse. CCS is not a program if someone only has a substance abuse. It's kind of there's a lot of individuals who have comorbidities and have dual diagnosis and have, mental illness and substance abuse, and those individuals who have mental illness and substance abuse, will receive those services through CCS, can receive those services through CCS. If the primary diagnosis is substance abuse, that would occur through their Quest or their QXA health plan. That individual would not come through into CCS. Did I answer the question?
Okay, there is a second part here,
Okay.
focused to Ohana, notes intention to continue coverage for substance use disorders to include methadone, but why not buprenorphine, with its higher adherence, multiple advantages clinically and greater safety for pregnant opioid users. It's very detailed.
Clearly, there was a clinician in the room
I
that
think
snuck that
so,
one in.
yeah.
And I'm
I'm
gonna make
sorry
my-
if I totally trashed that
to
question.
make my pharmacist come up here and answer that. Now, in all honesty, I think with the example on the slide was just that. It was just an example, i.e. methadone treatment. There's multiple different treatments out there. We're not stuck to just methadone as far as a treatment methodology. I think it was just up there on the slide as illustrative purposes.
Okay.
My pharmacist was nodding his head, so I guess I answered that correctly.
Yeah, great. How about what happens to Clubhouse? What is Clubhouse, and can you give us a little bit more information about that?
Clubhouse is a part of our psychosocial rehab group of programs. It's a specialized kind of program. It defines membership and joining, usually in a work order day. Very important program, community-based program for sustaining recovery. We've had clubhouses. Most of our clubhouses are operated out of our community mental health centers. They're separate but attached to our CMHCs. And by the way, if I could, our CMHCs actually operate a number of different programs, not just conventional clinic-based programs. So CMHC, Community Mental Health Center, Clubhouse includes Clubhouse, clinic-based services, jail diversion, and forensic teams, all of which are critically important in supporting individuals at a variety of different stages in their recovery. Anyhow, Clubhouse, part of our psychosocial rehab portfolio, critically important.
Oh, I'm so sorry.
Community support for individuals in recovery in communities.
I
Molly
also
has a
wanted to
question.
add that MedQuest
just got
does
everybody in.
recognize the benefits of Clubhouse and have really
Y'all gonna go, oh my God. Just say
tried
pick
for
out.
many
There's a
years to
question.
be able to reimburse adult mental
Correcting.
health
Molly
patients
has
for
a
the Clubhouse
question.
services that they
I'm
provide.
talking, but you got this. I'm serious.
And I really have quite a bit of hope that we will be able to get reimbursement from CMS for Clubhouse services effective October 1st. I was just on the phone with CMS last week, and we've got our fingers crossed that we're going to actually be able to get some federal reimbursement for that service, because we do think it's such a benefit, as well as we hope that the supported employment part that Adult Mental Health Division is providing, we can get some federal reimbursement. So it just allows us to continue to provide that service, to individuals when we're able to bring in the federal funds for that.
Okay, it looks like we have our neighbor island folks with us, at least via audio. I think we're flashing on the screen here. So let's go to our neighbor islands. Good morning, everybody there. I hope you're not too wet. I hope you're not too wet. So I'm not sure who's on first. Could we, Maui, Hilo, or Kauai? Does anybody have any questions? And you'll need to mute somewhere.
Yes, I have a question.
Can you tell us where you're speaking
Is
from?
I'm speaking from Hilo, and I'm glad to hear that you have an emphasis on continuity of care. And my concern on that is for youth who age out of CAMD and have a high gap because of CAMD services. What transition will address these young people? We all know that young people often run the experiment of medication noncompliance and get in trouble. Will you consider gap exceptions for young adults?
I'm not sure who's going to answer that.
So we will take a referral from CAMHD if CAMHD believes that this person can benefit from CCS, and we can do a transition to CCS. I do think that there is some gap groups surrounding children being served by CAMHD, and truly, if they meet that diagnostic criteria, or even if it's a situation where, CAMHD really believes someone could benefit from the services, then that's something they could work with our medical director, Dr. Toma, on. And I know Dr. Toma is in the audience, and I think would be willing to do that. So, but we can take referrals from CAMHD as well.
Okay. Either one of our other panels have anything to add to that? Okay. Thank you, Hilo. Is there another question from Hilo before we move to one of the other neighbor islands? Okay.
The licensure for,
Yeah, we do have one more question. Hang on.
Hi, there's a question from Hilo. I was wondering what the CCS program is going to do about the licensure issues for a lot of the POS providers under the Adult Mental Health Division, because they're very different right now for case management.
Okay, we'll get an answer.
So it's a little hard to hear. I think the question was, how do we intend to handle the requirement for the case managers to be licensed? And this has definitely come up, and obviously I'll let Patty chime in a minute. But currently today, you're right, the contract does state that to be a case manager under this program, you do have to be licensed and or supervised by a licensed person. So we understand with the movement of the AMHD staff and a lot of, in particular on the neighbor islands, some of the community mental health centers, there's clearly a shortage of clinicians. So this is identified during the transition of care period. We intend to work through it, but I believe DHS is looking at maybe some flexibility around the system, and I'll turn it over to Patty.
So, Wendy, thank you. We have not worked through all of the details with regards to, what the requirements are going to be surrounding licensure. But, we do understand that, we do want to have, if not someone licensed, someone supervised by someone licensed provide those services. And we will have to look at, where there's gaps in those services and work through that with Ohana. What we don't want to do is we don't want to have someone, we do believe there's value in maintaining case management and that value in maintaining that relationship with the case manager, and do want to continue that going forward. In addition, we do have with the CMHCs, we do have some special requirements in our state plan that surround who can provide those services. So, we will work through those issues with Ohana, and are very interested to hear from the provider community and, any information you can give us so that we can work through this correctly. We'd like that.
Okay, thank you very much. Still on the neighbor islands, do we have anybody from Maui or Kauai who would like to ask a question? Go ahead.
Maui's good.
Okay,
Good morning, this is Kauai. We actually have a question.
okay, please go ahead.
Okay, hold on.
Do I get near the mic? Yeah. Okay, so in 5 weeks, we roll this out. Is this the only training session we have? Will we have a consultant? And what about people in the United Healthcare and all the other plans? So I'm asking, how does this play out in the life of a worker, a Kauai Community Mental Health Center in 5 weeks?
So I think that we can answer this in two phases. I'm not sure if this is a question about adult mental health division workers and how that plays out from that perspective. It sounded like there's a piece of that. I do know that with regards to POS providers, Ohana has been out there and will continue to be out there doing provider training, and we will continue with that provider training. With regards to United Healthcare, we do have processes, kind of behind the scene processes. Once we receive that list from Adult Mental Health Division, we will actually identify who is from United and actually get some records to provide that to Ohana so they're aware and they can reach out to those providers to make sure those services are maintained. But I think there's also a piece about Adult Mental Health Division.
Yeah, if I heard it correctly, I think the question had to do with the individuals at the Community Mental Health Center. And as I indicated when I presented, that the folks served at CMHCs can continue to be served at the community mental health centers. That will continue through the transition, and they have to be reassessed, as everyone who's new to CCS will be reassessed, but their plan can continue. This is intended to be clinically non-disruptive, current site of care, CMHC, purchase of service, whatever, can continue. So effective September 1st, the main change really is who's going to provide for the reimbursement for the services, and it kicks off that reassessment or assessment interval for Ohana and CCS. But everyone served at a CMHC today can continue to be served at a CMHC in September, and continuing, if that's where they choose to be, as indicated by their reassessed plan.
And I think just to add real quick,
Who does,
I think just
who does the assessment?
I'll get that one too. So the CCS program vendor, which is also Ohana Health Plan, we would be going out and doing the assessment, the reassessment, as far as working with whoever the current treating provider is on the care plan. You know, the intention of doing a reassessment is just making sure that the member's receiving the right amount of services, there aren't additional services. Really a large part of our approach to doing these assessments is really to make sure that the member has an understanding of all the different choices available to them and the different treatment options. And I think that's maybe a little bit different. The former CCS vendor was also a provider of services, and we're not. That's not our business. You in the provider community, you were the experts in that area. That's not an area we have any intention of going into. So a lot of our approach with this was being able to offer consumers choice, whether that's choice of case management agencies, choice of where they're going to receive their services, choice of physicians. And I think just to back up just for a quick second, I think the only thing that might potentially be confusing a little bit based on a couple of the questions is Ohana is also a Medicaid health plan. And I think that's where it gets confusing is I think people are thinking, you know, what's Ohana going to do with maybe a United Health Plan member? And the fact that we are also a health plan, I really think advantages us because we're aware of how the medical side of things run. So we coordinate and collaborate with United Health Plan just like we collaborate with ourselves, which I know seems a little weird. And ultimately the goal is, you know, with the other Quest health plans when we go for the Quest transition in the next phase. But I think that's what people have to wrap their head around is, you know, it's two different programs within one company, which is Ohana Health Plan.
We have a couple other questions, like have you contracted psychiatrists and or APRNs who will do medication management in East and West Hawaii?
We already had that network in place previously as we had to for QXA as well as our Quest members. So really it's opening it up to CCS members at this point. You know, it's a challenge, not to minimize what's going on with access to neighbor islands. We've also been in communication with with our current case management agencies that provide the physician service and the physician coverage. And our goal is to keep that as intact as possible.
Okay, if there
Will there be a liaison between DHS and DOH during transition for providers to call?
We will continue to meet through an extended interval, probably regular meetings to monitor, update each other around small issues, big issues, interface issues. So we'll probably do that, I'm going to imagine, at least quarterly through the interval to make sure it's going well, that we're all aware of special problems that might arise, and that we've got an opportunity to problem solve and think through some of the process detail that we're not able to anticipate specifically today. This is forecast to roll out really over a period of time between now and early 2014 for those reassessments. There's nothing about it that's going to magically give our communities, our islands, our homes more providers, so we all are aware of that, and we've got to make sure that we're doing what we can to improve access, improve the quality of programs, and improve the focus on those services that people really need. And we're going to continue to do that together, both in terms of the programmatic issues, but also in terms of monitoring for outcomes, I believe, and monitoring for critical sentinel events. I think there's a commitment that we're going to continue to meet together and work with you around what can we do to continue to improve services, to increase the likelihood of positive outcomes, and to decrease negative outcomes for the folks that we serve.
I have a question from our.
Okay, let's take, please, one moment. Did you have something to follow up with Patty Bazan from DHS?
The one thing I did want to share is that we do have, and I think Kayla mentioned this a little bit earlier, but we actually have a web page on the DHS website, and that information, we will be posting information. So the presentation today will be posted on their website. We're actually video recording this presentation today. That will be posted on the website. We have contact information for Ohana, Adult Mental Health Division, MedQuest Division. That is on the website. So I think that I know it feels like this is the only time you can ask a question, but we will be doing a Q&A. We're actually gathering all the questions today, and we're going to do our best to get the questions from the neighbor islands. We have everything in writing from Oahu, so we will actually do a Q&A and a written response to that and post that on the website. We really want to make sure that we're keeping individuals informed as to how things are going through this. So we will give you that website before we leave at the end of the day. And I just wanted to let you know, because I think there was a kind of a part of that question: where do we go if we're a provider? Where do we express our concern if we have any issues?
Yes, I have a question. Somebody mentioned earlier people will have a choice of what provider they want to go to. I was wondering will individuals be allowed to split their care? For example, a psychiatrist from one provider and a case manager from another. Will that be part of the offerings?
If that's what the consumer wants and the providers are willing to collaborate and work collaboratively on an integrated care plan, absolutely, it would make no difference to us.
Going to Maui. Maui had a question. We've not heard from them yet.
Yes, we heard that there's gonna be there's plan to have two separate line, access line and a crisis line, or for eligibility. So is that true? And how is the how would AMHD then interface for those calls that calls into the crisis line or access line, interface with the contractor? So if there's an individual needing crisis services, how will that work, or how will that play out?
It's a great question. There are a lot of parts to it. Some is germane to this presentation. Some will be elaborated later. AMHD access will continue. We've come some distance with our improvement. We've got further progress to make. One of the things that we're looking at, AMHD access, is splitting off our eligibility function. And we're anticipating probably being able to do that within the next 60 or 90 days. That will improve efficiency at access, that crisis line, and make it less likely that a call get dropped and not responded to. That's separate from our interface with, I think, Ohana and the CCS program crisis line, but we're working together around that and have started talking about shared cases that call one line and really get service from the other, or vice versa, and we will continue to do that. So it's a start on that eligibility access split for us. More will be coming, so stay tuned.
Okay, I'm going to come back to Oahu, and we're going to focus on some particular populations at this point, and then we'll pick up again on the neighbor islands. Thank you for chiming in, folks. Really appreciate hearing from you. Have a card here. I work with people who are homeless and who have a pretty hard time finding psychiatrists to fill their maintenance needs for SMI, and they can't get any psychological talk therapy at all. Given the role of SMI in homelessness, how will this change increase accessibility to actual psychiatrists and psychologists who will accept their insurance?
So we provide that same access today across all islands for our Medicaid beneficiaries, just as we do in the CCS program. The clinical complication of homelessness and an SMI diagnosis, I think there's a lot more challenges to that approach to a member and getting them engaged in treatment that go well beyond whether there actually is a psychiatrist that's willing to accept. Our intention is to really partner with our case management agencies. This is where we see our case managers as really being able to impact that member, to be able to get them into the service, to be able to receive the treatment. I think it's really more of an engagement issue at that point than it is an access to care issue.
AMHD and ADAD, Behavioral Health Administration divisions, are going to continue to increase their programs addressing the needs of individuals who are homeless, homeless with issues around substance abuse, homeless with issues around mental health or mental illness challenges. We've got a ways to go. We're going to continue to do that and expand our programs addressing those specific needs. This initiative will help us focus on those programmatic areas to a greater degree.
So one of the new Medicaid services, behavioral health services that we're really trying to get approval for is something called supported housing, because we really believe in the housing first model. I mean, it's very difficult to have treatment, effective treatment when you're not really sure where you're living or how you're getting food and those kinds of things. So we do anticipate that, as Wendy's talking about working with case management agencies, that we will roll out a program called supported housing. And it's more than just case management. It's more than just, standard case management, but really trying to identify housing options and trying to get someone into housing, and then trying to work with that individual to address their clinical needs.
So just following up, because there's a second question here, not from the same person, but similar. So what happens to the current housing for AMHD members transitioned to CCS or OHANA?
We tried to speak to it directly. There's continuity for current individuals that currently reside in AMHD housing can continue in that housing with this transition. They can continue. They will continue.
And, when I talk about supported housing, Medicaid does not today and will not in the future actually compensate for the actual housing. I mean, we're not allowed to do room and board. But we are talking about, continue to partner with the Adult Mental Health Division as well as other state agencies on, what can we do for housing. But we're talking about actually helping someone obtain housing and maintain themselves in that housing. If we need representative payee to make sure rent's paid, those kinds of things.
Okay, next question, next category of population. How are the elderly being represented and cared for? As you age, loss of hearing causes anxiety, paranoia, depression. Will CAMD have their own building for services like community health centers do for the adults? Will there be a separate server, HCIL, to gather data for reporting? A couple different questions in there. Let's start with the elderly. Are they being handled differently than other populations that we work with?
No. I mean, if someone is over the age of 65 and has SMI, then they're eligible for services under CCS. But there are, this program is not for someone with dementia. I mean, that's a very different program and different ways that we handle that within MedQuest division. So I guess it depends upon what diagnosis you're talking about. But individuals with SMI or SPMI do age and will still be eligible for services.
Okay. Will CAMD have their own building for services? Or is that too far into the future? That's the way it's written, like the community mental health centers do for the adults. Yes. Yes. CAMHD.
We can't answer
yeah.
for CAMD's plan in that area.
Yeah.
What'd you say, family guidance centers?
Thank you.
Okay. And data gathering, is that a focus of this transition, or is that a little too far into the future just yet?
We do believe in gathering data, and we actually anticipate being able to have more data than we do today, because one of the things that Ohana will do and has already started doing is actually submitting data to us so that we can compile information and do reporting on that.
And we anticipate aligning some of the AMHD gathering in a way that permits more easy and appropriate comparability between what we're doing, what Ohana is doing, and also tracks individuals who have challenges across their various services better, again, to manage to reduce negative outcomes and to increase positive ones. So again, that collaboration that's going to continue will include important elements that have to do with looking at information, how people are doing, how are we doing in terms of recovery goals and avoiding bad outcomes.
Okay, I have a few more questions here, and then we'll go back to the neighbor islands and check in. These are more sort of logistics. What is the process from MedQuest to Quest Expanded Behavioral Program to Ohana and the CCS program for people with SMI? So my understanding is, does an individual, what is the process that the individual needs to go through to make any changes? I hope I understood that correctly.
So I'm not sure if this is a referral into CCS or if this is, I'm not really sure the exact question, but I'm going to try to answer.
Person here who wrote the question? Okay, please continue.
So, I mean, what happens is the MedQuest division receives referral information for the CCS program, and there's information to identify, what the diagnosis is, as well as, some functional criteria. And I think we went over that earlier in the presentation. So we receive that information, and we, have a psychiatrist review that information and then say, yes, this individual is going to go into the CCS program. And what we do is we bring them in prospectively. We don't do anything retrospectively, so everything is prospective. And, basically from the day we authorize they can come in, they come in 5 days later. And we transfer that data over to Ohana through something called an 834 file. We actually give them a data file, and they know who their members are who are coming in. And, that is how they process those files on a daily basis, and they receive that information on a daily basis. So MedQuest does have an ability to do that. Also, once we bring them into the CCS program, as Wendy had mentioned, we actually have on our DHS Medicaid Online, we have, if you go all the way to the right side of the page, a behavioral health tab. You can click on the behavioral health tab, and you can see that individual is in the CCS program, and it's called Ohana BH. So if you see Ohana BH, that's CCS. And so that identifies for the public, not for the public, but for providers, that someone is in Ohana. And then Ohana is responsible for sharing information with the member. Maybe you can go over that, Wendy.
So once a member has been accepted through the DHS process into the CCS program, a couple different things happen. But right off the bat, as soon as that file hits Ohana Health Plan, what we do is we start the process to mail them their eligibility card, their member handbook, explains a little bit about the program, and then it's identified in our behavioral health department for an outreach call from one of our staff to set up that assessment and be able to explain the program, go out, meet with the member, and ensure that they're connected to services. So it's another opportunity to kind of get in front of the member, explain the process, and explains what happened.
Okay. The most of the remaining questions are mostly structural. So if I could just ask three of you to emphasize the key points from your portion of the presentation, the fact that the whole idea is integrity of the program, smooth transition, those kinds of things. So just think about that for a moment. I'm going to check in with the neighbor islands, and then we'll come back to you. Neighbor islands, any questions outstanding?
From Maui,
Go ahead, Maui.
if CCS is going to operate their own crisis line, are they going to, do they anticipate operating their own crisis mobile outreach? Are they going to provide contract with existing providers? And how would that affect admission to licensed crisis residential?
So our crisis line isn't intended to replace the current statewide crisis line. I mean, I think the access line is well-known. People have the number, they know to call. I mean, it's, you know, anybody can call the access line. We have the same thing today. Anybody can call the health plan today, and if they're in crisis, it doesn't matter who they are. We've got our internal processes of how to kind of triage the call and handle the services, but we have no intention of taking over the general role the access line plays, or becoming a vendor of the crisis outreach services. So the current providers would still be the same providers that we anticipate would serve the members.
Any other questions from the
Thank
neighbor
you.
islands? Any other questions?
Question from Hilo? Question from Hilo. So for the, will you, the CCS case managers, will they help people to apply for SSDI? It's a lengthy process, and some of the people who are most impaired have the most difficulty filling out that 10-page form.
So our intention is we expect that these case managers are going to assist the member with whatever it is their healthcare needs are. We also expect they're going to help coordinate and collaborate with their health plan. Whoever that health plan assigned for the current QXA program, all of these members should have an assigned medical health plan service coordinator, and that's definitely something that we see should be done in collaboration, because a lot of that paperwork is likely also going to include some more of the medical diagnoses and need some of the medical data as well.
Okay. Do we have any other questions before we go to our wrap-up?
Yeah, so what happens with those that just have Medicare?
So this is a program for Medicaid beneficiaries. If someone does not have Medicaid, this program does not affect them. This is something that the MedQuest division, this is a MedQuest division program for individuals with Medicaid. So,
Current arrangements around service provision will just continue for a person covered by Medicare.
Okay, we're going to go to our wrap-up here, and I'm trying to get us to the last slide, which has the information that, contact information for us. But let's go ahead and begin with department, what? The other way? Can you get me there? Left click. The last slide is where I'm trying to get to. Sorry. There we go. Okay.
so transformation phases, just want to go through. We're looking at a date of September 1. This is primarily a reimbursement or a billing issue for providers. So providers will, September 1st, dates of service, bill, instead of Adult Mental Health Division, bill Ohana Health Plan. And, you know, really all services will be maintained, all services will stay in place, you know, through that assessment period and you know, until a plan of care is developed. So really, there should be no effect on the beneficiaries. September 1, it primarily is a billing issue effective September 1. And, you know, providers just really need to be, you know, just really need to plan, oh, I'm providing this service on September 15th. I don't bill Adult Mental Health Division. I bill Ohana Health Plan. So that's one piece. We will be transitioning. We will be working through and continuing to communicate with our providers and communicate with the consumers, but we will be doing something similar to this for Quest in 2014, and then our Quest integration plan, will be our last phase that we'll do, and that'll be January 1st, 2015.
Okay. Department of Health.
We want this to be clinically non-disruptive for our clients. We want to maintain clinical continuity and support people's recovery in their communities. That's most important. Crisis services, there's no wrong number. Call Access, call CCS. We'll work it out. We want people, eligible or not, any person in our communities who needs help should be able to call either line and get support. There's no wrong number. The impact on providers, as Patty said, change the place to which you send the bills after September 1st. That's the most, the specific change effective that date. Ohana will authorize, pending this reassessment. All previous authorizations will continue until that's in place. We want it to be clinically non-disruptive. If people are aware of clinical issues, we want to hear of them so we can go about joint problem solving.
And again, just in closing, from Ohana's perspective, our approach to this, and I hope that this is echoed in the provider community as well as with the advocacy groups, is we have been open and transparent. We intend to continue to be open and transparent about anything the program's doing, any changes as this moves forward. We've already met, we believe, with, I think, every single provider in the provider community. We've done a couple of forums. We'll do so also on the member side. So really, that's our approach. That's our dedication to this population. So we hope that came across today. We hope it's been coming across, and we hope to maintain that in the future.
Okay, so with that, a reminder that the slide presentation will be posted on the DHS website at the address given here. I go back one, left or right? There we go. Okay. The DHS website here will have the slides from today's presentation. Also on that page, once we get a video recording of today's session, I'll make sure that that's posted. We will be sure to link also to Department of Health. We'll coordinate with them to make sure that both sites have the same information. So again, no wrong number wherever you go. And if you have any further questions, your best bet is to contact the Adult Mental Health Division at Department of Health, and that number is there. Thank you very much to Patty Bazan, Healthcare Services Branch Administrator, Department of Human Services MedQuest Division, Mark Fridovich, PhD, Dr. Mark Fridovich, Administrator, Adult Mental Health Division, Department of Health, and Wendy Moriarty, President of the Ohana Health Plan, and to you, the public, and those of you on the neighbor islands. Thank you so much for coming out today. We hope your questions have been answered. If you have any other questions or concerns, do not hesitate to call us. Thank you so much. Oh, thanks. Appreciate it a lot.
They do the contract.